Dear friends, dear colleagues, I am Dr. Zbishi Ahmeddin from Algeria, and I am going to talk about a quick guide for the management of keratoconus. This is my reference, and this is the plan of my presentation. We know that the management of keratoconus has advanced during the last few years and still in progress. And there are traditional modalities and modern modalities of the treatment. These modern modalities are relatively new for us, and that's why the surgeon should be aware of their indications, contraindications, conditions, and complications. For the modalities, we have two options, the non-interventional options and the surgical procedures. And we have also a combination between these two options. For the non-interventional, we have spectacle correction and contact lenses. And for the surgical procedures, we have penetration keratoplasty, lamellar keratoplasty, intracorneal rings, cross-linking, or intraocular refractive lenses. And last is laser-based surgery like PRK. For the non-interventional options, we have spectacle correction in very early cases of keratoconus can correct the regular astigmatism and are indicated if we have best correction visual acuity, corrected visual acuity more than 0.6. And when we have a difference between corrected and uncorrected more than 2. Also, if we have a very low rate of high order aberration and refraction is less than -4. For the contact lenses are generally needed if we have a cylindrical power increase beyond 4 diopter, and if no significant difference between uncorrected visual acuity and best corrected visual acuity. In this case, for example, if we have uncorrected visual acuity 0.2 and best corrected visual acuity 0.3, we have to put in our mind two diagnoses. First is amblyopia of this eye or high order aberration. Contact lenses are indicated if we have corrected visual acuity less than 0.6 and the difference between corrected and uncorrected visual acuity less than 2. And in case of high order aberration, the RMS more than 0.37 or the refraction more than -4. For the non-interventional procedures, we have the keratoplasty, penetration keratoplasty. In the case of patient with keratometry more than 60 diopters and the corneal thickness less than 350 microns with central corneal scars. This technique in keratoconus is considered relatively low risk in terms of graft rejection. The second technique is deep anterior lamellar keratoplasty. The advantages of this technique is that we have less endothelial cell loss and less intraocular pressure problems after surgery. And we have also reduction in rejection episodes. This technique with using femtosecond laser technology is the first choice in the near future because it's effective, technically easy to perform. We can do it with local anesthesia, and it has a good visual outcomes and long-term graft survival and stability. The indications of talc regarding keratoconus are if you have anterior corneal scars and advanced disease with stress line and clear cornea, if the Kmax is more than 65 diopters and the thinnest location less than 350 microns, with a very high refractive errors, means a sphere or a cylinder more than -6. For the third technique is cross-linking. There are many protocols for the cross-linking. Dresden protocol, accelerated cross-linking. We can do epi-off, epi-on cross-linking. The first indication of cross-linking, if we have a documented progression in keratoconus. This is the criteria used to establish keratoconus progression for the cross-linking. The first criteria is the steepest keratometry or Kmax increase by 1 diopters from the baseline, or the keratometry mean more than 0.75 diopter. And in case of if the corneal apex power increase by 1 diopters from the baseline, and in the manifest spherical equivalent difference between the two spherical equivalent more than 0.5 diopters. And last criteria is the central corneal thickness, when we have a decrease more than 2% from the baseline. Other indication for cross-linking, when we have a keratoconus with age under 20 years old, in pellucid marginal degeneration, and if in case of form first of keratoconus before PRK. And the last indication is in corneal ectasia after refractive surgery. The contraindication of cross-linking include many parameters. If the corneal thickness is less than 400 microns at the thinnest location, but now there is many protocols for of cross-linking for thin cornea. And second contraindication, if we have a Kmax more than 60 diopters, if we have high visual expectation from the patient, and if we have also corneal epithelial healing or previous herpes keratitis. And the cross-linking also is contraindicated during pregnancy of when we have corneal scarring. Second procedures is the intracorneal rings implantation, and the indication are when we have a corneal thickness more than 350 microns at the thinnest location, and the Kmax reading less than 60 diopters. And when we have also refractive errors less than -6. And last indication is when we have a clear cornea with no central scars or stress lines. This is the factor of a poor visual outcome when we have Kmax more than 55 diopters, or the pachymetry at the thinnest between 300 and 350 and 400 microns, and when we have also paracentral opacities. The contraindication of intracorneal rings, if we have a very high visual expectation and controlled autoimmune disease and during pregnancy or nursing. This is contraindication are relative to the patient. And for the contraindication relative to the cornea, when we have a thickness less than 350 microns and Kmax more than 65 diopters, and when we have corneal scanning, we can do intracorneal rings implantation. This is the complication of the complication of intracorneal rings are rare and mostly related to the beginning of the learning curve. The traditional mechanic technique of tunnel creation can lead many complications, but using femtosecond laser for creation of tunnel has fewer complications, and the main one is posterior perforation. The intraocular refractive lenses, the condition of this technique are the same in a normal eye when we have the anterior chamber depth more than 2.8 millimeter, and we should have a stable refraction. This is the guidelines for managing keratoconus with intraocular refractive lenses. And when we have a stable keratoconus with spherical equivalent more than -6, we can manage or suggest to the patient to do intraocular lenses or ECR with intraocular lenses. For the laser-based surgery for the keratoconus, there is many protocols. We have Cretan protocols, Athens protocols, or wave front-guided protocols. In this surgery, we use the excimer laser associated with cross-linking. Generally, are indicated in early stage of keratoconus. And for the combination between treatment modalities, let's see some examples. First example is when we have a progressive case with high refractive error and a good best spectacle corrected visual acuity. In this case, we can suggest for the patient cross-linking with intraocular refractive lenses to stabilize the cornea and to correct the high refractive error. And the second decision, we do cross-linking with contact lenses if the patient is tolerant to this contact lenses. The second example, when we have a progressive moderate keratoconus with a moderate refractive error. So in this case, we can suggest for the patient to do cross-linking because it's progressive, and contact lenses or spectacles if the patient is tolerant, or we would suggest for the patient the intraocular rings after cross-linking if the patient is not tolerant. And the last example, when we have a stable case of moderate keratoconus with very high refractive errors and a good best corrected visual acuity. In this case, we can do intracorneal rings because we have a good visual acuity. Then after we can implant intraocular refractive lenses, and always if the patient is tolerant and tolerant for the contact lenses. Now we will see together the different parameters to study a case of keratoconus. There are general considerations regarding evaluation of the patient. Using RG contact lenses must be stopped for at least 2 weeks. Corneal topography should be done with the Scheimpflug image, and it will be more accurate when combined with placido imaging. The progression of the ectasia can only be determined by follow-ups. And last consideration, the family history should be really considered. And taking the right decision in treatment of keratoconus is not a simple process. It depends on important parameters. First parameters are related to the patient. We have age, sex, environment, patient's refractive error, and uncorrected and best corrected visual acuity. We have also progression if there is a progression or no. And this is other parameters related to the cornea of the patient, thickness, and K-max reading, transparency of the cornea, and existence or no of stress lines. We start with the age. We know that the high risk of the progression is in a younger age. The more elastic the cornea and the more response to the treatment of the cornea. Complications of cross-linking in patients older than 35 years old are frequent. And for the age, if we have keratoconus in a patient under 20 years old, we have to do cross-linking without waiting for progression. And if we are, the age is between 20 and 30, we have to look for the progression. If is stable, we can suggest to him to do a cross-linking and PRK. Second parameters is the sex of the patient. We know that the keratoconus progress in female more than in males, and both technique, cross-linking and intracorneal rings, are contraindicated during pregnancy. And if we have a case of keratoconus in female, we have to put in our mind it can be progressive, and the cross-linking can fail in this situation because of the multiple pregnancies. For the environment, the incidence of the disease increase in dry and cold areas where cases are found to be more aggressive and in younger ages. Close follow-ups of the patient's young brother and sister who may develop the disease. For the progression, rarely after 30, and this is the criteria that we have seen above to establish keratoconus progression in cross-linking. The fifth parameter is the corneal thickness. We know that the thinner the cornea, the higher the alert for the advanced disease. And it's contraindicated to cross-link the cornea with corneas if the corneal thickness is less than 400 microns. And it's not useful and not reasonable to implant intracorneal rings in a thin cornea, less than 350 microns. For Kmax, it is well known that with high Kmax, more than 58 diopters, the response to the intracorneal rings decreases and the complications after cross-linking increase. For the refractive errors and visual acuity, we have to mention the manifest spectacle refraction, cycloplegic refraction, measuring uncorrected and best corrected visual acuity. And this is the recommendation. If the sphere or cylinder is less than -3 diopters, we can suggest for the patient to do cross-linking and or without PRK. And if the sphere or cylinder is between -3 and -6, we can suggest intracorneal rings. And if the sphere or cylinder are more than -6, we have to think about intraocular refractive lenses or deep anterior lamellar keratoplasty. And for the last parameters, corneal transparency and stress lines. When the cornea is not transparent, we should think about penetration keratoplasty or dark, and in the the dark is usually indicated. Now we will see different strategy to manage keratoconus. This is the parameters that we have seen above, and we put them in a table like this, and we have to answer about question to answer to the question about all of these parameters: transparency and stress lines, yes or no; age, progression; contact lens tolerance, yes or no; refractive errors in spherical equivalent less than -4 or more than -6 or between; difference between the best corrected visual acuity, Kmax, corneal thickness, and sex. And finally, we can suggest a treatment or a protocol for this case. For the transparency, if the transparency is central, we have to do a dark or PKP. If paracentral, we look to the best corrected visual acuity. And if clear, we have to look to the age. If the age is less than 20, you have to do cross-linking to stabilize the cornea. And if it is more than 30, the progression is rare, we can suggest for the patient a treatment. If between 20 and 30, we are not sure for the progression, so we can observe and follow up the patient every 3 months or every 6 months. For the contact lenses, if there is a patient is tolerant, we can suggest for him to wear the contact lenses. If no, we have to think about other modalities. If the spherical equivalent is less than -4, we can suggest for him cross-linking and PRK. And if this is more than -6, we have to think about dark. Between -4 and -6, we can do intracorneal rings implantation. For the difference between the best corrected visual acuity, if we have a difference less than 2, we should think about deep anterior lamellar keratoplasty like first options for the patient. The Kmax, if we have a Kmax less than 58, we can suggest for him other options like intracorneal rings or cross-linking with PRK or intraocular intraocular refractive lenses. If more than 58, we should think about the dark. For the thickness, less than 350, we have to do dark. For more than 400, we can do other options. Between 300 and 400, we can do cross-linking, hypotonic cross-linking, and we can do also dark. It depends to the visual acuity of the patient. And finally, we will see together one case of keratoconus. It's 19 years old, male with a progressive refractive error in both eyes. And the patient presents a blurring of vision and he is intolerant to the contact lenses. This is the manifest refraction, and this is the old refraction of the patient. Where we take the left eye, and we see that there is a difference in the sphere and cylinder. And this is the topography of the patient. We have Kmax 47 diopters, and the thinnest location is 492 microns. So try to put the parameters in this table. We have the cornea is transparent without no stress lines. Age is 19, so we can suggest for him cross-linking. For the progression, most probably yes, so we can do cross-linking. For contact lenses tolerance is intolerant, so we think about other modalities. For the refractive error spherical equivalent, we have -3.2 to 25 diopters, so we can suggest for him cross-linking or PRK or intracorneal rings. The difference between best corrected and uncorrected is 3 lines, more than 2. So we can suggest for him cross-linking, PRK, or intracorneal links. Kmax 47, less than 58. So always cross-linking and PRK. For the thickness, we have 492 microns, so we can cross-linking and PRK, and also intracorneal links. The sex is male, so we see that this table that the suggested treatment is cross-linking because it's progressive, and we can the cross-linking we can suggest for the patient with or without PRK. For the discussion, it's a mild case of keratoconus, which does not need aggressive procedures to be managed with. And as the case is progressive, the cornea should be cross-linked. And as the refractive error is small, less than -4 diopter, sorry, here, then tennis location is good, more than 450. PRK is a good choice for this case. So the decision we make is cross-linking with or without PRK. Thank you for your attention and bye.